introduction. I'm very delighted to be here to listen to all these nice talks and to share also some of my experience related to AMR. So I will try to. Do you see my slides?
Yes, sir.
Okay. So again, welcome everyone. So here are just my conflicts of interest. And this is probably a slide that you have seen many times. It was one of the very first report that really mentioned the crisis we're going through and even how worse it could get if nothing is done. And maybe one thing that people don't have read, it's that Jim O'Neill gave us also some clues on how to curb with this problem. And one of the key issue that he indicated was rapid diagnostic. And rapid diagnostic, it's useful for the drugs, because at one point we will have new drugs arriving, and they're here, as we have heard from Professor Livermore and Jean-François Timsit. So we have to use them very well, and to use them very well, we need to infer the resistance mechanism, but we need it also for surveillance, and surveillance is very important because at one point we have also to inform the public about the crisis each country is going through. So rapid diagnostic is very important, and in France, it's really one of the key component of the fight against this multi-drug resistant bacteria, because we have a strategy called search and isolate, which means we have to look for these multi-drug resistant bacteria, mostly carbapenem resistance, in order to reinforce hygiene, to have dedicated staff, and even in some hospitals we have cohorting units. But also, as we have heard just by Jean-François Timsit, rapid diagnostic is very useful also to antibiotic stewardship, because with these novel molecules, we know that some will be active against KPC, OXA48, or metallo-beta-lactamases. And we have also heard that a patient that is colonized by a multi-drug resistant bacteria may get eventually infected. So Jean-François Timsit said 15%, but in other studies, they come up with 40% of the patients that are colonized get infected. And then, of course, there is, even though molecular testing is expensive, there is cost saving, reduced moral cost, and avoids patient care. Another two important papers is that just came out recently. It's the World WHO bacterial priority pathogen list, for which we need new antibiotics. And of course, carbapenem resistance are top chart list of these bugs. And the recent report released by WHO on the glass indicates that among all the resistance mechanisms that are currently emerging, carbapenem resistance is really the one that is emerging a lot. In Klebsiella, it's 15% over the last 6 or 7 years, and in E. coli, it's about 12%. And Acinetobacter, as we heard, is also a key pathogen. So carbapenem resistance is really a key player in antibiotic resistance. So carbapenem resistance is something that we know for a very long time. As soon as carbapenems have been introduced, we were selecting, sometimes through therapy, a bacteria that became resistant to carbapenems, and this happens through impermeability problems and an enzyme that hydrolyzes very weakly carbapenems. This is, of course, a problem for the patient because these bugs are almost impossible to treat anymore. They're highly impermeable to any drug, but there is no epidemic dissemination. And these chromosomal mutations have a high fitness cost for the bacteria. So as soon as you stop antibiotic therapy, these bacteria have the tendency to disappear from the hospital settings. With carbapenemase enzyme that hydrolyze very strongly carbapenems, it's different because they're coming with highly epidemic clones. They have so-called high-risk clones. They're plasmid encoded, so they spread very easily in hospital settings. And this is the dilemma that we are facing from time to time in the hospitals. You have 6 bacteria that are highly drug resistant. Most of them have reduced susceptibility to carbapenems, and yet they are not equal. And of course, to keep a long story short, if you look at this, you would say, okay, these bacteria are difficult to treat. Maybe one is susceptible to ceftazidime, so we could use ceftazidime, and so on and so forth. But basically, we need rapid diagnostic tests just to infer which one is a high-risk clone. So we have 5 carbapenemase producing isolates and 1 that is a CTXM15 with impermeability. And in France, CTXM15 plus impermeability, standard contact precautions for hygiene, for infection control is sufficient, whereas for all the other ones, we need to reinforce hygiene. So it's very important to know what the mechanism is underlying these resistance phenotypes, because the consequences for infection control are different. But this is not the only reason. The other reason, and Jean-François just explained that, and David Livermore as well, said that according to the carbapenemase that you have in your bug, the treatment will be different. I'm not going to go through all these antibiotics again, but just an example, if you have KPC, it's ceftazidime avibactam. If you have OXA48 alone, it can be ceftazidime or even aztreonam, whereas if you have OXA48 plus ESBL, it's ceftazidime avibactam, and for MBLs, it's more complicated. It's aztreonam avibactam and so on. So knowing which enzyme is present will allow you also to implement the right antibiotic therapy. So when we look at the literature, there are many tools now out there that you can use to infer whether a bacteria is producing a carbapenemase or not. You have phenotypic tests. Some work quite nicely, but they take 24 to 48 hours, which is way too long for at least infection control management in the hospital. Then you have carbapenem hydrolysis tests. There are many commercialized now. You could use them and they work quite nicely as well. But again, they don't detect all the carbapenemases. Then you have molecular tools. Molecular tools, we've heard, you have many different ones, and we will see a few of them. They work also very nicely, but again, you will only detect what you're looking for. And then what I consider for at least confirmatory testing, the best to choose is lateral flow immunoassay. And if you look at all these assays and you compare them and you look at the time to results, no doubt lateral flow immunoassay provides you a result in 15 minutes, but in most of the cases when it's positive, you get the results in generally 1 to 2 minutes. The price, of course, those are commercially available tests, so there is a price, but again, compared to molecular testing, it's way cheaper. You don't need any cold chain. Room temperature is fine, whereas for all the other ones, you need enzymes that have to be stored at -20 or +4. You don't need electricity. You don't need trained personnel. I mean, we're all experts now in lateral flow immunoassay because we all had to swab our nose and do some COVID testing at one point. And the sensitivity and specificity are very good, and I will show you a few papers that clearly show that the sensitivity is even better than molecular techniques. Again, all these assays, they work quite nicely, but they all have limitations. And in order to use them, you have to know these limitations. Limitations is basically you only detect what you're looking for, and sometimes you have sensitivities that are not too good. So why lateral flow immunoassay? Because lateral flow immunoassay, it's really a very easy test to do, and you can do it everywhere. We have even collaborators in sub-Saharan Africa. They have no electricity in their lab from time to time, and yet they can infer whether they have carbapenemases or ESBLs or other enzymes. It's affordable, it's sensitive, it's specific, it's user-friendly, you don't need any training, it's rapid, less than 15 minutes. You don't need equipment, and it's deliverable. And you have very long shelf life at room temperature. And for those who visited sub-Saharan Africa, sometimes room temperature there can be 35 to 40 degrees. So they're quite robust. And these are the assured criteria from WHO. So it's one of the only assay that really fulfills the WHO assured criteria. And there are many assays out there. Here are just a few of them that are commercially available. That once detects the 5 main carbapenemases, detects all the ESBLs of CTXM family, and who detects MCR. And the reason I brought those 3 up is because those are the targets that are also detected by multiplex PCRs, such as the one that Jean-François Timsit mentioned, BioFire. But there are many more of these tests available. There is one that detects VREs, Van A, Van B. There are OXA23 strips, OXA23, 40, 58, 140, all the oxacillinase from Acinetobacter. GES, PER, VEB. We heard that VEB may infer, and PER may infer cefiderocol. So these assays are available. They're RUO, which means research use only, but they're available to help you assist diagnostics. And this is exactly what we're doing at the French National Reference Center. Before lateral flow immunoassay, we were doing PCR. Now we're doing lateral flow immunoassay as the first intention, starting from an antibiogram. When it's positive, we sequence the isolate. This is for epidemiological purposes. If it's negative, but the antibiogram is compatible with the CPE, we do hydrolysis tests, and this helps us to catch maybe the minor carbapenemases, such as OXA23 and others in this assay. And per year, we perform 5,000 tests, and most of them are correct. We miss a few carbas by lateral flow immunoassay, but we catch them by hydrolysis tests. So this is very good, and this has now been introduced into the guidelines of the French Health Society, where lateral flow immunoassay is advised to do the confirmatory testing. So can we do directly on clinical samples? This is, of course, a very important question because we need to be able to treat very quickly. So here are just a few examples. We could have added also some respiratory samples, but basically, classical way is you do sampling, you spread, or you make a culture, then you do antibiogram, and then you reach the result 48 hours afterwards, and then you can do your favorite immunochromatography to infer the presence of an enzyme or not. You can speed up by doing testing directly on growing cultures for rectal swabs. Usually you use chromogenic media, selective media, and you can do confirmatory testing. And the same for urine samples. You could do the same, and you could have already an idea of what is going on. But can we do more? Can we work directly on blood cultures? Can we directly work on urine samples or blood or rectal swabs? Of course, when lateral flow immunoassay was commercially available, many people thought, oh, we can use them directly on blood cultures. And here are just a few examples of papers where they used this test. There is a lot of hands-on time because you have to remove the blood, you have to centrifuge, you have to wash, you have to lyse and wash and centrifuge again. It's a lot of hands-off time, but in most of the cases, they showed that you get a very good result on blood culture. And the result was even better than molecular assays, such as the one from Cepheid, because unlike Cepheid that does not detect IMP2 variants, CABA or lateral flow immunoassay detects all the IMP variants, which means it gives a better result. And in Singapore, they even evaluated this assay against whole genome sequencing, and they found 97.7% agreement between the two techniques. So a rapid assay that allows you to rapidly infer the presence of enzymes that hydrolyze your favorite molecule, such as carbapenems. And of course, there are commercially available assays now that are also available that you don't need to do all this big hands-on time, which allows you to have in less than 5 minutes your samples on the strip, and in 2 minutes later a positive signal, and it works perfectly well with CTXM and also with CPEs. What about molecular tool? We heard from Jean-François Timsit that molecular tools are very useful, especially for respiratory samples. And indeed, when you talk about molecular tools, you always think it's much faster, which is not necessarily the case. Lateral flow immunoassay takes 15 minutes, molecular takes 1 hour. It's more accurate, highly sensitive and specific. Yes, it's true, but you also detect, as we heard, some remaining DNA that may lead to a wrong diagnostic. It's easier. Well, that's not always the case. Some are very easy, are plug and play, but not all of them are like this. And of course, they are perceived as more expensive, which is the case. Of course, they are more expensive. But with a medical added value, this is a price that many institutions and many hospitals are ready to pay. So talking about molecular, most of the molecular assays are polymerase chain reaction based, PCR based assays. We have the PCR assays that are considered as point of care. And the best example is Cepheid PCR, which is a small cassette which can detect up to 5 targets. So it's something that is quite limited in number of targets. And then you have something that is much broader, which are high multiplex, more called syndromic PCRs, which allows you to detect many, many pathogens, viruses, fungi, and bacteria, and also some resistant genes. So according, of course, what you're looking for, you can use either one or the other. The ones that are the most used now, at least in many countries, is the syndromic PCR. Syndromic PCR, you have many different ones. We have heard about the respiratory panel, pneumonia panels, we have gastrointestinal panels now, meningoencephalitis, bloodstream infections, also urinary tract infection. Basically, any biological samples now, you have multiplex syndromic panel that allow you to detect the most important pathogens, and in some cases also the most relevant resistant genes. And in fact, when you look a little in the literature now, and if you go to several congresses such as ESCMID or in the US, you see that there is a big blooming of these assays. And really, it's a big market, and the market is developing very rapidly. You have, of course, some that are more present, such as BioFire from bioMérieux or ePlex that has been now purchased by Roche. Both assays provide results in 30 to 90 minutes, and they have a panel of almost 40 targets that can be amplified. So, of course, these assays have been evaluated, and this is just one study where these assays have been evaluated. It is a multi-center study. They did it on positive blood cultures, and on positive blood cultures, they could show that overall specificity and sensitivity was 98%, which is very, very, very good for these assays. But again, one limitation and why the specificity was not that good is that you detect only what you're looking for. And in some cases, there was a pathogen that was not included in the assay. And then, of course, you will not be able to detect it. And as Jean-François Timsit just said, OXA23 or OXA40, which is Acinetobacter baumannii specific oxacillinases, they are not detected by these assays. And then, of course, you will not see them and you will miss them. But overall, at least for the targets that are included in the assay, detection is very good. So this is what is currently developed and implemented in many hospitals, but some people are already looking ahead of this. And one of them is Gianni Rossolini in Italy. He wanted to see whether we can use now real-time whole genome sequencing to infer the presence of bacteria in positive blood cultures. And he used the nanopore technology. It's a small device that looks like a USB stick where you load the DNA and you can run the result. And by doing this, he managed to get the bacterial identification in 2.6 hours. So positive blood culture, you do the extraction, load on the flow cell, you get the result in 2.6 hours. 2.6 hours is the time almost of a PCR. And if you want to have the resistome, he could get the resistome within 4.2 hours. So 4.2 hours is very compatible with the daily life of a laboratory. But again, you detect only genes and you don't detect expression. So this is, of course, something that you have to keep in mind, that even with PCR, you detect only genes and not expressed genes. But this is certainly something that will probably develop in the next future. Again, for bloodstream infections, we have many, many PCRs that have been developed. Some are simplex PCR, some are small multiplex, and of course we have the large syndromic panels, but most of them work on blood cultures. But the next step will be directly PCR or metagenomic on blood. And this, you have a few examples here, T2 resistance panel or Magicplex sepsis, which work directly on blood. No enrichment through blood culture. You do it directly on blood. Of course, it's something that you cannot do on every patient because in France, many blood cultures are negative. So you will not be able to waste these costly the tools on this. But for some patients, ICU patients for which the risk of bacterial infection is very high, it's very probably advisable to use this strategy. But when you compare all these techniques with what is currently available, of course, you have classical susceptibility testing, which takes 24 hours. There is no many devices that have been developed to get a rapid IST. So rapid IST, you have rapid RAST, which is advocated by UCAST. But you have other techniques which can provide susceptibility testing results within 2 to 6 hours. So again, it's something that is compatible with the daily life. You have, of course, the molecular tests that we have seen, which are very fast as well, usually 1 hour to a few hours. And then we have now the latest ones, the tests that are in development, and some of them have already been commercially available, which allows you to detect directly inside of the blood the presence of bacterial isolates. So this can be done by metagenomic or by PCR analysis. So to keep all these things together, so classical way to handle analysis of a blood culture is, of course, 24 to 48 hours. What you can do also, and there are many assays now, you can do directly MALDI-TOF on a positive blood culture, which allows you to identify which pathogen you are. And what we do in BSET, we don't do it directly on the blood culture. We spread the bacteria on a plate let it grow for 3 hours for gram negative, 4 hours with the gram positives. And this allows us to give microcolonies, and these microcolonies we can then directly use on Malditoff, which gives us the identification of all the pathogens. We have seen that you can do syndromic PCR. It identifies the main pathogens responsible for blood-brain infection, but not all of them. You detect genes, 5 main CARBAs, CTXM, and MCR1. You can do whole genome sequencing. This is probably something that is coming up in the next few years, but it's going to be very costly at the beginning, but it's certainly a possibility. And then you have lateral flow immunoassay that you can do directly on blood culture. It takes 15 minutes. It detects proteins, so express the genes, and basically you have assays that cover all the genes that are also covered by the multiplex PCR. And I would even add, you have assays that detect also the oxalocarbaphenemases from Acinetobacter. And what we do also in our laboratory, since we spread the bacteria every blood culture on a plate, we do biochemical tests to get all the carbapenemases that are missed by the CARBA5, and we do the lateral flow immunoassay that detects the 5 main carbapenemases. This way you have really a good picture. So this is just to show you that you have costly, expensive techniques, but you can also get around and have almost the same kind of results by using cheaper assays, and maybe they take a little bit more time, but at least are as good. And then, of course, what we need to know is whether a patient is colonized by multi-drug resistant bacteria. So basically, this is done by rectal swabs. You plate it on chromogenic selective media, what the colonies that grow. Sometimes you have to do enrichment culture. This is when we know that someone is coming from an area where the prevalence is very high. We don't take a risk. We make an enrichment growth in order to increase the chances of detecting maybe a bacteria. And then you do your favorite immunochromatographic assay or your favorite assay to infer the presence of a CARBA or an ESBL. Here, of course, molecular techniques are the most useful because they detect basically one bacteria present in the swab. It's again, that's where it's really the most suited. But even there, our Greek colleagues have shown that for ICU patients in their hospitals where the prevalence of KPC is very high, they use lateral flow immunoassay directly on rectal swabs. And by doing this, without pre-incubation, they succeed. They had 80% of detection sensitivity. And by doing 3 hours of incubation, they reach nearly 100%. So by doing 3 hours pre-incubation, you achieve 100% with lateral flow immunoassay. So it's comparable to what molecular assays can provide. So AMR is a world health problem. It's rising everywhere. And one thing that we know from the old Chinese is that being aware of a difficulty allows you to avoid it. And rapid diagnostic is really in the heart of this because it allows you to handle this problem in your hospital. Of course, you will not be able to prevent a patient that comes to the hospital that is colonized, that will get infected. You will not prevent this, but you will prevent the transmission from one patient that is colonized or infected to another one. So we have assays that are now highly efficient, they are rapid, affordable diagnostic tests, but always keep in mind that there are hands-on tests. They do not replace classical microbiology because we still need to test for susceptibility. And we just heard from David Livermore that KPC may evolve by mutation. And even though we consider KPC as a carbapenemase, when it mutates, it becomes resistant to ceftazidime avibactam. It also becomes susceptible again to carbapenems. And basically, in literature, there are cases where they have treated successfully these variants with carbapenems again. So we need to do susceptibility testing. It allows us to have an idea, but it's certainly not the way to go. So most are validated for the epidemiology, the global epidemiology. None is perfect. Knowing the limits of these assays is very important because then you can really use them and have a critical viewing of results. They are rapid. We have very rapid tools now, which can provide results in very high, in a very fast manner. And as I said, lateral flow immunoassay, it's really an assay that is quite affordable and fulfills all the criteria of the assured criteria for WHO. We have syndromic multiplex PCR, which, as Jean-François also explained, they're highly useful because they allow you to detect very rapidly in complex matrices, and respiratory matrices are really probably the way to go because in there you have only a few bacteria which cannot be detected by any other mean. They are costly. This is one problem. So you have to use them to the best way in order to avoid that the costs explode. But for ICU patients, I guess everyone will agree that you need to have a rapid identification in order to put up the right antibiotic treatment. And of course, you can only use all these assays if you have a diagnostic stewardship and an antimicrobial stewardship program available. Doing diagnostics, fast diagnostics, without having all this, it's worthless, because behind the result, there must be an action. And the action goes through antibiotic and antimicrobial stewardship. And these assays have to be well thought and have to be integrated in your clinical workflow. And this is one usually big problem, that there is a delay in prescription, there is a delay in sampling, transport to the lab. So this is something to be optimized, because if you really want to provide a fast result, everything pre-analytical has to be very fast as well. And of course, the microbiology lab needs to function 24 hours out of 24, 7 days out of 27, including molecular testing, of course. So this is probably one limitation of the implementation of this assay, is that it has to be done in a timely manner in order to provide a result.